Welcome to video 16 in the Safe Recovery Training Program. This video focuses on delivering the Safe Recovery Program in real life. I'm Terry Haines. The objective of this video is to learn how to implement the Safe Recovery Program in a flexible manner to fit in with the existing programs and services at your health service or hospital. Ideally, when providing the Safe Recovery Program to individual patients, you want the education program and first review to be completed within the first week of the patient arriving on the ward. If you're providing the Safe Recovery Program on an acute ward with a shorter length of stay, you'll need to make this within the first couple of days of their admission. Timing is important. Asking someone to spend time discussing falls when they're not feeling well or if they're in pain does not help the patient to perceive that you are on their side. Also, be conscious of patient fatigue levels. You don't want them falling asleep halfway through your presentation or discussion. Again, the point of this activity is not to get the task done, but to develop a relationship that will help patients to reduce their risk of falling while in hospital. The timing of the video generally allows an information gathering conversation to be taking place with another patient while the first one is watching the video. So if you start a conversation with a patient, take about 15 minutes to do that and then set them up to watch the video, you can go see another patient during that 15-minute period that they're watching the video and then come back while you set the second patient up to watch the video. You can see approximately 3 patients per hour this way. Alternatively, you could conduct a couple of review appointments or do some other paperwork in that video time. But in any case, try and make the most of the time while the patient is watching the video. I would always encourage you to value add to existing falls prevention initiatives that are already in place on the hospital wards that you're providing the Safe Recovery Program. Whether this be things like mobility boards, or gait aid based mobility prescription tools, or falls prevention rounds. Falls prevention rounding is quite common these days. So certainly being able to provide input to those rounds would be invaluable. The first version of the Safe Recovery Program conducted at the Peter James Centre actually incorporated the gait aid mobility prescription tool as a part of the education materials. We had a system whereby we would put 3 stripes on gait aids where patients needed assistance to walk around, 2 stripes if they only needed supervision, and 1 stripe if they were independent. And we incorporated that into the training program. With selecting the right patients, again, as you'll recall from video 2, the evidence indicates that we should be providing the Safe Recovery Program to patients who are cognitively intact. In the research, we've used a range of different generic screening measures, such as the abbreviated mental test, the short portable mental status questionnaire, or the mini mental state examination, each with the cutoffs that you can see there to indicate that a patient is cognitively intact. Now, it is recognized that these are gross screening measures of cognitive function, and that factors such as education level or whether someone is a native language speaker of the language that you're applying the test in can affect test scores. Also, test scores can change over the admission, and some flexibility is required in applying these cutoff points. So if you think the patient, well, they didn't score quite high enough, but I still think they're okay to receive the intervention, or if that's the opinion of the clinical staff, then you can be flexible with who you select to provide the program to. Modification of the program is necessary in certain situations. The first situation I'll give an example of is the patient with extreme fear of falling who is already asking for help. Again, the video presentation assumes that most patients are underestimating their risk of falling while in hospital, and as a result they're not asking for help as much as they should. Now, although this is in my experience true in the main, there are some individuals who that's not true for. So you need to adjust how you provide the program for these patients. I would avoid actually showing the video at all to these patients, and I would instead encourage participation in therapies. I would still go through, though, the hypothetical scenario where you deal with the fall that the participant believes is most likely to occur and set goals to help them to identify strategies that they can use to prevent that fall from occurring. I would, of course, revisit these patients as their mobility improves, and I would make sure that if their situation changes, that their fear of falling has been addressed, then you might be able to go back towards more of a mainstream education of that patient. Feel free to be flexible, though, with program delivery to meet the needs of the individual patient and their situation. Another example of modifying the program that I'll share is when we had a patient who had extreme emotional distress about another issue. And in this example, it was a patient who had had a stroke, who had recently lost her son, who had passed away. And for this patient, in their mind, it was still very recent, still very raw for them. It was unexpected. And the grief process for the patient took precedence in the patient's mind ahead of anything else to do with their own care. Now, for this patient, it's going to be very difficult to identify a leverage point and something that you may not even want to go and venture towards. You can listen to their story and build an emotional bond with the patient. In this patient's case, we were surprised to find that no one had actually done this yet. And she was very grateful for this. So as a result, we were able to give the patient a simple strategy related to asking for help whenever they needed to mobilize. And we relied on the do it for me. So we asked them that could you just do it for us for the next couple of days as you get used to being in the hospital and as you get used to the rehabilitation as things settle down for you, as motivation. And because she was so grateful that somebody had taken the time to listen to her story, it took about 15 minutes, she said she was willing to give it a go. And when we reviewed that patient, she was in a better state of mind to have a discussion about falls. So sometimes delaying things and letting the patient settle down into the hospital environment may be needed to have a successful relationship with the patient and to be effective in providing the safe recovery program. When discussing with patients the things that are upsetting them on the wards, how they're finding the wards, quite often they will complain. And they will complain about the actions and activities of staff members. And at times, we've come across situations where the actions of staff members have been very questionable. Dealing with this is a balancing act, because we need to ensure that the patient perceives that we are on their side. However, there are usually two sides to every story, and we need to be diplomatic in how we handle that situation. It is not our role as a safe recovery program provider to run off and fight the battles for the patient. Now, of course, if you encounter something which could have broken the law or is an example of malpractice, then yes, we do need to take steps of escalating that to ward management. However, in our role in providing the safe recovery program, the primary focus is always to consider how the patient can best deal with the situation that they're in. So always listen, validate, but then redirect and try to refocus the patient on things that may be constructive to help them to have a safe recovery while they're on the ward. Now, some of this information that you'll come into contact with, you'll think, oh, if we could address that on the ward, it'd be great. It'd be something that improved the safety of patients, and many of our patients are complaining about this particular issue. Again, it's particularly going to happen if you've established a good rapport with patients, that they will be open and honest with their disclosures with us. If we have collected this sort of information, we again do need to be tactful with how this information is communicated to other staff. We certainly don't want to go running out of the room and confronting a staff member and accusing them of certain things, behaviours or practices, and then having that staff member go back into the room and have a go at the patient for saying those sorts of things to us. So that would completely break down the trust and the confidentiality of the discussions that we're having with patients. What we really need to do is consider the component of clinical practice that's requiring modification and think about the best way to modify this. Remember, in the Safe Recovery program, simply providing the education to patients was a way that we were able to reduce falls amongst cognitively intact patients by about 30%. But we got a bigger reduction by being able to use the information we collected to inform usual care practices and communicating this with the other team members. And this led to the biggest reduction we've seen in the injury rate, the first time we've had a significant reduction in the injury rate. So with the information that you collect, is it that related to formal procedure that staff are doing? Is it related to an informal procedure? Is it related to how some of the staff are interacting with the patient, or whether the patient's trying to interact with the staff? Or is it related to some sort of attitudes the staff are displaying? So have a think about what might be the appropriate course of action to try and remedy the problems that you've identified. I would suggest having a periodic meeting with unit leadership to report on issues being raised by the patients. I would log the issues as they're identified by patients. I would group them together and count up how often they're being spoken about by patients. And I present this information in a depersonalized manner, not mentioning patient names and not mentioning staff member names when feeding back to the unit leadership. I would focus very much on the formal procedures and informal procedures, the work practices and routines that are being followed, along with, I guess, general attitudes as well. And I'll try and link this into existing management structures. So if your ward has a ward-based falls prevention committee, then certainly linking this information into the falls prevention committee will be vital. The quality improvement cycles used in our hospitals very much follow the plan, do, study, act process. And certainly the information that you collect as a part of the Safe Recovery program will inform the plans that go into quality improvement for falls prevention locally, but also they can involve the evaluation of strategies that are implemented to try and reduce falls further. So if you find that as a part of your first month of going around and providing the Safe Recovery program, that 50% of your patients are complaining that when they're taken from bed to a chair, that their call bell for the nurses is left out of reach, you can reevaluate that. If a strategy is put in place to try and address that, whether it be a staff education program or an awareness raising program, and then the following month reevaluate that, and if that's dropped down to say 1 in 10 patients, again, that's great information to be able to feed back to the staff on the ward to let them know about the success or otherwise of the strategy they put in place. With documentation, I would encourage dates of interactions with patients to be documented, the key findings from the information gathering to be recorded, particularly regarding threat appraisal, whether the patient perceives that they are at risk of falling over while in hospital or not, document whether the video was shown, what key strategies or goals were set, and whether these strategies were achieved, and any new goals or strategies during review appointments. There are some frequently asked questions that are usually posed to me at the end of this course. The first is, can the Safe Recovery program be provided in a group scenario? During 2001 and 2002, when I was developing the first version of the Safe Recovery program, I initially intended it to be provided in a group setup. However, we experienced a number of issues that led me to believe that that should not be the case. We found that patients were less likely to give open and honest disclosure of the issues they were facing in a group context, and that may not be because they haven't developed a bond with the therapist providing the program. Rather, they possibly hadn't developed the bond and trust in the other people within the group to keep that information confidential. Some of the information that is shared with us during this program is very personal in nature, and some of the issues that are addressed can be very painful for patients. So providing the Safe Recovery program in a one-to-one format for me is the best way to do it. The other issue, of course, is running a group in a hospital context when not everyone is at the same level is very difficult. The Safe Recovery Program isn't a program where you can have people in their first session combined in with people in their last session very easily. Normally we provided up to 4 sessions for the Safe Recovery Program per patient. However, some patients required less, some patients have required more when we've run the studies in the past. The next question is, can the Safe Recovery Program be provided by volunteers? Now, potentially yes, although I am uncertain as to how effective it would be. In every study I've conducted so far, I've used either physiotherapists or occupational therapists, people with health professional backgrounds and experience working in acute or aged care environments to provide the program. So although it potentially could be provided by volunteers, I am uncertain as to how effective it would be. Can a nurse caring for a patient provide the Safe Recovery Program to that patient? I would recommend avoiding this if at all possible, because many of the issues the patient might want to raise might relate to the care that that nurse is providing to the patient. So having a separate person who is independent of the ward staff, at least in the mind of the patient, I think is the best way to get an open and honest disclosure of the issues that are affecting that patient. Final question, are there any restrictions on providing the Safe Recovery Program? No, you may provide the Safe Recovery Program. Please do cite, if you're going to write up a paper about how wonderful it is, please do cite the papers that I've been providing in the videos so far, and please encourage broad use of this program. Again, the purpose of these videos is to get this evidence-based strategy out there and being used in real life. Finally, please complete the survey linked to the end of this video to provide some information to me so I can know which countries are using the Safe Recovery Program, what sort of hospitals, and so I can get your suggestions for any improvements I can make to this training course, whether that be the removal of my very poor jokes that I've scattered throughout these videos, or something else of a content matter. Thank you very much for your time in being a part of the Safe Recovery training program, and I wish you the best of luck in providing this program at your hospitals locally.